purpose of the grand rounds is first is the knowledge, update a new evidence, guidelines, technologies in a core and a subspecialty topics. We always feel that enhancing the skill, diagnostic reasoning, operative planning, management strategies can be increased by joining the grand rounds. We can also learn the professionalism, how to discuss the ethics, the communication, the patient experience, safety, and culture. And the idea of Grand Round is again the community and the mentoring and the system improvement.
Good evening, friends. And at outset, I am very thankful to Dr. Kawita Bapat and congratulate her for this nice initiative for academics. Today, I'm going to talk about myometrial pathologies that confuse us the most. We know that adenomyosis and fibroids are the commonest myometrial pathologies that we come across, and the differential diagnosis between these two is very, very difficult and often confusing because both present similarly, both have similar effect on the fertility, both also on ultrasound have very similar pictures. So let's see more in detail into both of these myometrial pathologies and try to differentiate them confidently. Starting with adenomyosis, primarily it is a disruption of the inner myometrial architecture and the function of the inner myometrium, also with secondary infiltration of the endometrial elements into the myometrium. What is the prevalence? Very difficult to actually even think about or imagine or even presume or because it is very, very common. It is especially more common in infertile population. But the most important thing is that this condition, though has variable presentations, as we will see further, a lot of them are asymptomatic and are just diagnosed as incidental finding, and therefore the correct incidence is very difficult to evaluate. But yes, it is true that in the infertile population, its prevalence has been seen to go to as high as about 70 to 80%. Histologically, it is the endometrial glands, which, because they penetrate into the myometrium, when they are found deeper than 2.5 millimeter from the endometrial myometrial interface, or there are some other workers would also say that the endometrial glands is in extending 1 to 3 millimeters below the endometrial layer, or there are still some more literature evidences which say foci of the gland situated deeper than 25% of the total myometrial thickness. But that means that the endometrial glands go beyond the junctional zone. And when this happens, that is when histologically it is diagnosed as adenomyosis or it is stamped as adenomyosis. Yes, it is true that there are lots of ultrasound signs which very clearly indicate the presence of adenomyosis, but the gold standard is still the histopatho. Coming to if it is so prevalent, what is the cause of it? And the cause basically is the uterine trauma. How does this uterine trauma occur? It may occur because of any previous surgery, as simple as it may be just a curettage or maybe evacuation of a failed pregnancy, or even because of natural abortion, and even because of any delivery or any obstetric event that has happened. So it may be iatrogenic, but it may also be spontaneous. And the chief reason is hyperperistalsis. Now, why would hyperperistalsis occur? It has been suggested that the trauma activates the mechanism of tissue injury and the repair. And it is this tissue injury and repair which results into inflammation, ultimately results into increased local production of estrogen. And it is because of this increased estrogen that hyperperistalsis occurs. Because there is hyperperistalsis, there is minor trauma, micro traumas to the muscle layer and to the junctional zone. And it is because of this that, again, there is trauma, inflammation, increased estrogen, increased movement, and increased peristalsis, and again, increased trauma, and it becomes a self-perpetuating process. Moreover, it has been also documented that the smooth muscle cells, which are present in the adenomyotic uterus, are ultrastructurally also different from the muscle cells of the normal uteri. And this is also understandable because when we talk about the adenomyotic tissue, these are the muscle layers. So the myometrium, the adenomyotic myometrium, it has continuously been exposed to trauma and inflammation, and therefore there is a morphological change which occurs in so the ultrastructural morphological change that occurs into this muscle layer, and it leads to ultimately cellular and nuclear hypertrophy. We did talk about presentation, and I also told you that it is often asymptomatic. But yes, when it presents, it may present as menorrhagia, dysmenorrhea, dyspareunia, metrorrhagia, subfertility, abortions, and of course, asymptomatic and incidental finding, as I already told you. The rest of the symptoms are understandable, but why would it lead to a problem with the fertility, or why would it lead to abortion? And the reason is because of the deranged hyperperistalsis, and moreover, because of the damage to the inner layer of the myometrium, which is the junctional zone. It also leads to inadequate blood supply. Moreover, it releases toxins, and it also has an immunological basis. With that impact on the patient's life, not just the quality of life, also fertility, we must be able to diagnose adenomyosis on ultrasound. And what is the most important or the most evident sign on ultrasound? Most of the times we would find that the uterus is enlarged. And this is what is often reported as a bulky uterus. But mind you, there's no word like a bulky uterus if we look into the scientific description of the ultrasound findings of adenomyosis. It is actually a globular uterus. The uterus, which is normally pear-shaped, it because of the chronic inflammation and edema and a lot of extra tissue, which is endometrial tissue, it actually bulges out, and this leads to the globular shape of the uterus. It may be globular generalized if it is a symmetrical bilateral upper and lower, anterior and posterior, both walls of the myometrium are equally involved. It may be a symmetrical globular enlargement, or it may be an asymmetrical globular enlargement if it is one wall which is more involved. But it is basically a globular enlargement. Whenever it is asymmetrical, it is important that we would compare the thickness of the anterior wall to the posterior wall. It is measured at the same level from the outer margin of the endometrium to the serosa. And that ratio would tell you that it is, if it is not 1:1, it would tell you, yes, it is an asymmetrical thickening of the uterus. Then coming to the second very commonly used term for the description of adenomyosis, and that is heterogeneous myometrium. And what do we mean by heterogeneity? There would be hyperechoic lines, there would be hyperechoic dots in the myometrium. There would also be some hyperechoic islands, as you can see here in this case, somewhere here. And you're also seeing some hyperechoic islands here. And this all make the myometrium look very, very heterogeneous. So it's hyperechoic dots, hyperechoic lines, hyperechoic islands. And here they are not seen in these two images, but we'll see in further images. The myometrial cyst is one more finding which is important to document. So the hyperechoic dots and lines, hyperechoic islands, and the anechoic myometrial cysts, these are considered to be direct signs of adenomasis because these are because of actual invasion of the endometrial tissue into the myometrium. But the other signs that we document or we report in our ultrasound scans is Fenn shadows, junctional zone abnormality, question mark sign, enlargement of the uterus, which we described as globular, altered vascularity are all indirect signs of adenomyosis. Let us look into more detail of these. So if we look into, and this is very beautifully explained by in the latest amendment of the MUSA guidelines for adenomyosis, which says myometrial cyst, hyperechoic islands, hyperechoic dots and lines are considered direct signs, whereas asymmetrical thickening, symmetrical or asymmetrical thickening, Fenn shadows, here it is a translational vascularity and irregular junctional zone or interrupted junctional zone are considered as signs of adenomyosis. And indirect signs of adenomyosis. So whenever you see this hyperechoic lines and dots, that is when it may be seen that they are seen deep. You are also seeing myometrial cysts here. You also saw some myometrial islands, endometrial islands here. And these all may be spread throughout the entire myometrium in the cases where there is in the long-standing cases or in the cases where the diseases are spread to the deeper layers of the myometrium, but otherwise it would be seen in the junctional zone. It may be seen in continuity with the endometrium, as you have been seeing here also. The lines, when you see, they may be perpendicular to the endometrium, and whenever you see them, theoretically, you must write the location and the number. But at least if you write the location of these lesions, it would be helpful if it is an asymmetrical involvement of the myometrium by adenomyosis. Some more images here where you're seeing multiple myometrial cysts, you're seeing myometrial island, you're seeing hyperechoic flex, and moreover, you're seeing here alternate hypoechoic vertical strands, which are also seeing here, which are called Fenn shadows. Myometrial cysts so far has been found to be one of the highest or the most specific sign for diagnosis of adenomyosis. And actually it is heterogeneity. So if we grossly take it as heterogeneity, which is one of the very sensitive and specific sign. But if we go to into more detail of heterogeneity is the myometrial cyst, which is most common. Now, myometrial cyst, earlier it was said that the myometrial cyst would always have a hyperechoic outer margin, but the latest amendment 22 has now shown that, mentioned that the hyperechoic lines may or may not be there. It's not essential that they would always be there. And you are seeing here lots of myometrial cysts which do not have hyperechoic margins, but they're still called myometrial cysts. Again, the size, it was considered earlier as minimum 2 millimeters. Now it's minimum 1 millimeter. So any myometrial cyst you see is one of the most important signs. And you're beautifully seeing the Fenn shadows here, alternate hyperechoic, hyper and hypoechoic vertical strands posterior to the, or deeper to the, to the lesion. Whenever you see myometrial cysts, just like your hyperechoic dots and lines, it is essential that you would not only mention, if there are multiple, you need to mention the spread of it, the location, and then again, if they are large enough, you need to measure the size and write down what is the size of the largest and what is the location, upper, middle, lower third, right, left wall, or it is in which layer of the endometrium, whether it's junctional zone, it is the middle layer is up to the vascular arcade, and out of that is the outer layer of the myometrium. Moreover, it is MUSA guidelines which insists on writing down the type of content, whether it is anechoic, low-level echogenicity, ground glass echogenicity, or mixed echogenicity. But this probably is more theoretical, even if you mention the extent of the myometrial cyst and the measurements of the largest one would suffice, and the depth at which they are. Then coming to the junctional zone, which is the next very commonly described feature of the adenomyosis. And you can see here, instead of a normal junctional zone, which is seen in this part of the uterus, you are seeing here it is a thickened irregular junctional zone. Whereas in this layer, you are seeing the junctional zone is being traversed by the hyperechoic line, making it interrupted. And sometimes it may be completely inaccessible. The junctional zone, of course, can be seen on 2D, but on 3D, it can be seen much better. And you can actually identify the junctional zone and outline it as clearly as with MRI if you're using a 3D ultrasound. And you can also see its irregularity. You can see the endometrial strands extending inside. You can measure the thickness and compare it with the thinnest part, and so compare the thinnest part and the thicker part also. If your section is cutting at the right layer, you would also see the endometrial strands extending into the myometrium, again an irregular junctional zone here, normal here and irregular, abnormal here. Again, it is interrupted here and here it is irregular. Apart from this, on your 2D scan, you would also see the abnormal shape of the endometrial cavity, where the endometrial cavity in its fundal half takes a reverse curvature beyond the mid-body. And this is described as a question mark sign. And this is attributed to either asymmetrical involvement of the uterus in adenomyosis or adhesions. Sometimes, because of focal adenomyosis, you may also see a local compression of the endometrium, leading to an abnormal shape of the endometrium. And this is also a sign of adenomyosis. Going to the Dopplers, a typical vascular pattern that the adenomyosis has it is absolutely chaotic arrangement of the blood vessels. Instead of the vessels in the inner layers of the myometrium, which are arranged parallel to each other and perpendicular to the endometrium, they are chaotically arranged, as you can see here. Not only that, they have a larger diameter than the normal spiral vessels, and moreover, if at all the lesion is focal, you would see that the vessels, they disregard the margins of the lesion and they just run through and through. And this is what is described by Musa as a translesional vascularity, which is absolutely unlike the fibroid, which has a peripheral and intralesional vascularity. Intralesional is where the vessels are restricted by the outer peripheral vessel or the outer margin or the muscular hypertrophy. They do not cross that margin. If I said that the vessels have a larger diameter and they have a chaotic arrangement, that does not mean that all the adenomyosis are hypervascular. There may be hypo or hypervascular adenomyosis, and when it is hypovascular, that's when it is a very little chance that it will respond to the medical line of treatment. So many times it does happen that you might have given medical line of treatment analogs to the GnRH analogs to the patients to reduce the adenomyotic bulk, but they do not respond at all. And this is dependent on the vascularity of the adenomyosis. That means that ultrasound really is very, very helpful. And you can also use MRI when the visibility is poor with ultrasound, and the reported diagnostic accuracies of ultrasound to detect adenomyosis are comparable to MRI and histology. And the sensitivities range from 75 to 88%, specificities from 67 to 93%. A systemic review has concluded that they offer similar high diagnostic accuracy compared to the histological examination. Now, if we know that the adenomyosis often is not symmetrical, it does not symmetrically involve the uterus, that means that it may have variable involvement, and depending on that, they have been the uterus can be classified into various types of adenomyosis. And not only that, they may also present in different ways, in the sense some of them may show no cystic areas, some of them may show only large cystic areas, and depending on that also, it has been classified by the MRI people into different groups, and they call it focal or multifocal. They call it superficial, asymmetrical, because the other wall is not involved. There may be superficial involving just the junctional zone, but symmetrical. It may be diffuse involving the entire thing, but still asymmetrical. It may be diffuse, symmetrical, globular enlargement of the uterus, symmetrical involvement. It may be a solid adenomyoma. It may be a cystic adenomyoma. It may be a polypoid, which they call it a submucous adenomyoma, or there may be a subserosal adenomyoma, or there may be anterior deep infiltrating adenomyosis or posterior deep infiltrating adenomyosis. Yes, it is true that this is an MRI classification, but the ultrasound doesn't use this type of a classification, but it still divides the presentation of adenomyosis into 4 distinct groups. And the first one is the diffuse involvement of the adenomyosis, which is called diffuse adenomyosis. And here you're seeing a focal adenomyosis, where you can very beautifully see it is this part of the myometrium which appears abnormal, which appears heterogeneous. But if you're moving across, you're seeing margins which are very faint. They're not very clear. Whereas the third one is adenomyoma, and the fourth one is the polypoid adenomyosis. Just let us quickly see as to what it is. Adenomyosis, when we say diffuse involvement, that means that more than 25% of the entire myometrium is involved. And then you may call it symmetrical if it is both the walls of myometrium involved, and you may call it asymmetrical if one wall is more involved as compared to the second wall. And you're beautifully seeing here the fan shadows also. But fan shadows are not essential for the diffuse involvement, just by the way showing you. Coming to the focal adenomyosis, yes, you have a lesion which is fairly defined, which is fairly confined to one area of the myometrium. It is less than 25% involvement. But it appears like it is localized, but you do not see the margins very clearly. And this is what is called a focal adenomyosis. This is surely different from the adenomyoma, wherein you would, I mean, here, if you see, there is the myometrium surrounding is absolutely normal, whereas here in adenomyoma, if you see, there is, yes, focal involvement of the myometrium with adenomyosis, but there is an outer hypertrophic myometrium. So it is this myometrial hypertrophy which makes it look more like a fibroid. But I would just want to remind you that because these are some common features with fibroid, with myoma, that is why it's called an adenomyoma and not a focal adenomyosis. So what are the common features? It is comparatively fairly well defined, and it is it has peripheral hypertrophy. Not only that, when you switch on the Dopplers, it would show some scanty peripheral vascularity. But then what is different? What is different is, if I told you about the fibroids, and if I told you that the vessels are confined by the outer peripheral vessels, if you look into the adenomyosis, though they have some peripheral vascularity, they disregard the margins of the lesion and they just run through and through. So the inner vascularity is still in translesional vascularity. So that's how you can differentiate the adenomyoma. So that is focal adenomyosis, that is adenomyoma. So to keep it all together, make it simple to understand, it is a focal adenomyosis if there are circumscribed nodular aggregates of the endometrial glands and stroma surrounded by the normal myometrium, whereas adenomyomas are the subgroup of focal adenomyosis surrounded by hypertrophic myometrium. Coming to the polypoid adenomyosis, we do see endometrial polyps, and some of them, they do not appear homogeneous. They may appear heterogeneous in echogenicity. And if you put on a Doppler, they'll not show a single feeder vessel alone. They would show branching of these vessels. And this tells you it is possibility of an adenomyomatous tissue in this polyp, which you may call it adenomyomatous polyp, or you may call it polypoid adenomyosis. This appears very similar to malignancy. It is very important, therefore, that whenever you see this, it is you should measure do the spectral Doppler and measure the flow in the largest part of the vessels, and the RI should not be less than 0.45 to be not to suspect atypia. There is also one description which is called cystic adenomas. Actually, multiple tiny adenomatic myometrial cysts may actually get fuse together. They may join together to make large anechoic lacunae, and this is often described by some as cystic adenomas. And these cystic lesions, they do have peripheral vascularity. Apart from this, there is one classification which also says external and internal adenomas. Generally, we know that it is the endometrial tissue which from the endometrium traverses the junctional zone and goes into the myometrium, and this is where the inner layer of the myometrium is involved first always, whereas sometimes it does happen that the adenomyosis, the uterus involvement occurs through the endometriotic patch into the bowel, so it is out from outside to inside, and that's when the junctional zone still appears normal, but there is involvement of the outer myometrium first, and this is called an external adenomyosis. So this is again one example of an external adenomyosis, and it is in this lesions that you would find either a bowel lesion or you would see an endometrioma and the ovary fixed to the uterus and the lesion extending from there beyond into the uterus. Coming to the fibroids are benign tumors of smooth muscles and the fibrous connective tissue. The prevalence of clinically significant fibroids peak in the perimenopausal years, declining after the menopause. The presentation is very similar to what we described for the adenomyosis. But the large fibroids may also have some symptoms because of bulk or the pressure on the adjacent organs. Going to ultrasound, there is an enlargement of the uterus. It is always asymmetrical. There may be a focal lesion, a localized lesion, which may be round, oval, or lobulated. It is usually hypoechoic. It is well defined, and it shows a very clear margins. On the 2D, you would also see, just like the fan shadows that you see in the adenomyosis, apart from the fan shadows that you see in the you see the fan shadows in the fibroids also, but you see apart from that a very strong posterior hypoechoic bold shadow, which is called the edge shadow. So because it arises from the edge of the lesion, it is called the edge shadow. Though usually it is hypoechoic, the fibroids are hypoechoic, the echogenicity may increase with the fibrosis and the vascularity, and therefore the fibroids which are degenerated are often likely to appear more hyperechoic and more heterogeneous. Coming to the fibroids, its typical vascularity is a peripheral vascularity, and these are myometrial vessels which are displaced because of the lesion. This is not an invasive lesion, so it displaces the myometrial fibers, and it is this peripheral vascularity which has a very high specificity and sensitivity for the diagnosis of fibroids. If I said when they get degenerated, that's when they will change the echogenicity, become more heterogeneous. They may actually appear heterogeneous with hyperechoic and anechoic areas. They may also sometimes show cystic degenerations. They may sometimes appear generally hyperechoic, and this often happens when there is either a lot of fat content in the lesions, or there is sometimes it may also get calcified and may show calcified capsules. So there can be differential appearances of the fibroids. Now, whenever, therefore, you describe fibroid, it is essential that you would not only mention the that there is a localized lesion, you need to mention its shape, round, oval, or lobulated. You need to mention its echogenicity, whether it is homogeneous or heterogeneous. Need to mention this heterogeneity is because of the cystic lesions or it because of calcification. Of course, you can identify cystic degeneration, you can identify calcification, but when the fibroid appears hyperechoic like this, you do not know it is because of fat, it's because of myxoid degeneration, or it is because of rate degeneration, though rate degeneration generally appears more heterogeneous. it is important that you also document the echogenicity of the rim, and you can see here clearly the rim is hypoechoic and here it is hyperechoic, and that needs a mention. Coming to the degenerated fibroids, I told you it is heterogeneous echogenicity, which we described. If we go to the vascularity, there is a peripheral vascularity, but there is also intralesional vascularity, which I described already. The vessels which are seen inside the fibroid, they do not extend beyond the peripheral margin. They do respect it, and therefore it is called it is not called translational, it's called intralesional vascularity. If we say so, now if we consider this lesion, it may be, may be difficult to differentiate this degenerated fibroids from focal adenomasses, from adenomyomas or focal adenomyosis. And what are the differentiating signs? The first and the foremost is the difference in the margin. The fibroids are quite well defined, they're fairly and highly well defined, whereas when we talk about focal adenomyomas, they are, you can, if you look at it closely, you can identify the margins, but they're not very evidently well defined. They do not show their margins very evidently. Talking about the focal adenomyosis, talking about the fibroids, apart from that, they will show edge shadows, which are not the case in the focal adenomyosis, but in cases of adenomyomas, you may sometimes see some shadow which appears very much like edge shadow, but if you actually walk through, you will find out that these are not actually at the edge of the shadows. They're a little inside, but so they are very strong fen shadows. The margin is somewhere here. They're very strong fen shadows, but they may there is not an edge shadow. So edge shadow, one is margin, second is the edge shadow, which is a very typical differentiating point between the fibroid and the adenomyomas. The third is, if it is a focal adenomyoma, there is going to be some break in the in the junctional zone. As you can see here, there's a focal adenomyosis or adenomyoma. Now, this is adenomyosis, though this is not an adenomyoma, but you are seeing whenever there's a focal lesion, even if it's a focal lesion involving with adenomyosis, you would see the break in the junctional zone, whereas if it is a fibroid, it will only displace the junctional zone. It will not break it, it will not interrupt it. Vascularity, we have already described, translesional for adenomyosis and adenomyomas, and peripheral and intralesional for fibroids. There is one more modality that you can include to differentiate between the two, and that is called elastography, which assesses the firmness of the tissues. We know that the fibroids are always firm in tissue, and if you use elastography, which records the the consistency of the tissue as a rainbow spectrum, wherein the dark blue is firm and the red is fluid, you can see the fibroids are always dark blue, and even if they're degenerated, as you can see here, but if it is adenomyomas, they are going to be light blue or green in consistency. So they're softer. So that is one more way you can differentiate between the two. And the last and the very important, very evident is the contrast injection. And the ultrasound vascular contrast that are available, Sonovist, Levovist, Sonoview, you can inject it intravenous, and then you can do the scans. And that's when, if it's a fibroid, you're going to see first the rim lighting up, and after that, the contrast spreading into the entire lesion, whereas it has a starry night appearance when you look at the adenomyosis, and you can actually see the contrast, tiny spots of contrast spreading into the entire lesion. So that is adenomyoma. Now, if it is a fibroid, if we know that it is ultimately a myometrial lesion, it has to arise in the myometrium, and ideally it should confine itself to the myometrium, but we know that it does extend towards the mucosa, it does towards the endometrium, it does extend towards the serosa, and depending on its penetration, it has been divided into various types by FIGO. So this is a FIGO classification. You can call it a palm coin classification, wherein the fibroids which are completely inside and pedunculated, we call it type 0, or type 1 when it is less than 50% intramural, type 2 when it is more than 50% intramural, type 3 when it is touching the endometrium but fully intramural, type 4 completely intramural, type 5 is less than 50% so more than 50% intramural, but otherwise subserosal. Type 6 is more than 50% subserosal, and you would have outside the uterus, which is pedunculated, which is type 7. And then if it is in the cervix or the broad ligament, you would call them type 8. So it is ultrasound which would actually help you find out all different types of adenoma, fibroids, the penetration. You can do it on the 2D ultrasound. As you can see here, this is type 0, this is type 1 maybe, and this is type 4, which is completely myometrial. Here, this one, which extends from the endometrium to the serosa, we call it a hybrid fibroid. We call it type 2-5 because this matches 2 and this margin matches 5. You may have type 6, type 7 outside, and type 5 touching the serosa, and so on. Now, so you need to mention, if you're recording, if you're documenting a fibroid, it is important to mention it involves upper, middle, lower layer of the lower part of the uterus, right, lateral wall or anterior posterior wall. You need to mention the penetration, and especially when the penetration is type 4, so it's a type 4 fibroid, it is essential that you would mention the minimum distance of the fibroid outer margin from the serosa and from the endometrium, and this will help you identify the route of surgery. When it comes to when we talk about the route of surgery, we need to think about the submucous fibroids, because these fibroids may be more approachable from the endometrium. And we know that we have divided these into type O, type 1, and type 2. Naturally, type O and type 1 appear to be more approachable from inside the uterus. Now, that means by hysterectomy, hysteroscopy, but it is important that you would always do this systematically, find out and to help out what should be the correct line of surgery, correct route of surgery for this patients who have type O1 or 2 fibroids. You all must be aware LASMAR score, or a step W classification, has been established by Lesmar et al., which considers the size of the lesion, the topography, upper, middle, lower, the penetration, that is the type, the extension on the endometrium, and whether it involves the lateral wall or not. And depending on that, they have been given a score. Depending on the total score, you can decide what should be the type of surgery, whether it would be a low complexity hysteroscopic myomectomy, or the hysteroscopic myomectomy is not at all indicated, and you need to go for a more open approach, or maybe a laparoscopy. Especially when we're talking about the type O fibroids, it would be important, because they're completely inside the cavity. It is important to differentiate these fibroids from the polyps. And the important differentiating point is that the polyps, they're ecogenic, whereas fibroids, they're hypoechoic. So polyps are better seen in the periovulatory phase. Fibroids are better seen in the secretory phase. They stand out as hypoechoic areas. And the second is the vascularity. If you put on the Doppler, see a ring of color tells you it's a fibroid. If you see a feeder vessel, it tells you it is a it is a polyp. Moreover, if you cut at the correct point, that is when you would see that if it is a fibroid, it will pull in the junctional zone, whereas if it is a polyp, the junctional zone is just going to be completely intact. And that is these are the three differentiating points between the subendometrial, intraendometrial fibroids that cause infertility are submucous fibroids or large intramural fibroids. And when they are large intramural, they actually interfere with the myometrial contractions, as well as may compress or distort the endometrial cavity. And this can be very beautifully appreciated on the 3D ultrasound compared to the 2D ultrasound. Even the fibroids, which are close to the cornu, that is also where it is important to do a 3D and find out the exact depth of the lesion so that you would know that the cornu is involved or compressed by the fibroid or not. That means that the correct fibroid mapping is very, very important, and fibroids or focal adenomases or adenomyomas, when they are there, when you report them, they need to be, you need to mention the size in 3 diameters, 3 longest orthogonal diameters, the echogenicity of the lesion, whether it is homogeneous or heterogeneous, whether, how are the margins, and if it is heterogeneous, you need to mention what is the echogenicity, what is the cause of heterogeneity, the margins, whether well-defined or ill-defined, ream, as we talked earlier, which is hypo, hyper, or isoechoic, the shape, whether it is round, oval, or lobulated, type, whether that means the penetration. You need to mention the location, the vascular pattern, and of course the vascular score. And moreover, it would be best to give a pencil diagram of the same. But if you have a 3D software for the fibroid mapping, which really helps beautifully to exactly locate the fibroids, and just to save time, I would just fast forward this and we would directly go to the volume of the uterus. Having taken the volume of the uterus, we just need to outline the endometrium or the outer margin of the uterus. And when that is done, the machine automatically locates the fibroid, the uterus and the endometrium. You now have to outline and locate the fibroid, and once you have done that, the 3 diameters of it, that's when the computer automatically with its AI locates the exact fibroid, and its location in relation to its relation to the endometrium is also located. Even if there are multiple fibroids, you can not only beautifully see them, you can actually rotate them and find out whether these fibroids anyway are going to come in the way of the implantation or not. So that is about the description of the fibroids or adenomasses that we have discussed already. The last thing in the myometrium is the enhanced myometrial vascularity. Any large vessels that you see in the myometrium, if they are not to be documented as enhanced myometrial vascularity, it is very important that when you say enhanced myometrial vascularity, which was earlier called as myometrial AVM, uterine AVM, this is it's very common and it's very normal to see large, well-defined vessels in the outer or at the junction of the middle and the outer layer of the outer part of the myometrium. And this is very, very common when patient has undergone any obstetric event. But when you see that there is absolutely ill-defined anechoic areas or severely hypoechoic areas and heterogeneity in the myometrium, as you're seeing here, and this is also associated with a history of a previous failed pregnancy, which might be normal or abnormal. And along with that, you're also seeing heterogeneity in the endometrium. And then if you put on the Doppler, you would see the continuity of the vascularity, the abnormal vascularity that you see in the endometrium to extend into the myometrium. And it is this which is called the enhanced myometrial vascularity. So it's very important as to what is to be diagnosed as enhanced myometrial vascularity. And whenever there's an enhanced myometrial vascularity and there is an associated history of RPOC or the endometrium shows the signs of RPOC, that is when you can, you know what is the cause of that enhanced myometrial vascularity. It is penetration of this conception products into the myometrium. In these patients, you would put on a Doppler, pulse wave Doppler, and you would see that the velocity is very, very high. And this tells you these are the patients who may require occlusion of the blood vessels by way of uterine artery embolization, or you may give them methotrexate so that the RPOs everywhere in the endometrium as well as in the myometrium would regress. So that is the enhanced myometrial vascularity, and thank you very much for your patient hearing.